Caitlin Weaver.
I'm Ashley Vanderlip.
Nancy McAllister.
And I'm Ashley Transu, and today we're going to be talking about pneumothorax.
A pneumothorax is the presence of gas within the pleural space between the lung and the chest wall. There are several types of pneumothoraces. You have primary spontaneous pneumothorax, which is usually caused by a bleb that has burst. A secondary spontaneous pneumothorax, that is usually present when lung disease is already diagnosed. And a traumatic pneumothorax, which is usually caused by blunt trauma. Signs and symptoms include changes in depth and quality of respirations, altered chest excursion, use of accessory muscles, dyspnea and tachypnea, cyanosis and abnormal ABGs, hyperresonant on percussion, diminished breath sounds on the affected side, hypotension and tachycardia for tension pneumothorax. Also, some pneumothorax may be asymptomatic, usually on the primary pneumothorax. Diagnosis includes a chest x-ray or a CT scan. This picture right here is a pneumothorax on the right side with a mediastinal shift.
Evidence-based practice tells us that large pneumothoraces are best treated with a tube thoracostomy, also known as a chest tube. Recent studies have shown that small pneumothoraces may resolve on their own spontaneously. As nurses, it's important for us to continually assess our patients in order to use the best treatment and prevent complications. Here are some interventions that we can use. First, we must determine the type and cause of pneumothorax in order to use the proper treatment and properly place the chest tube. Next, we must assess respiratory function and vital signs, because respiratory distress and changes in vital signs may indicate shock due to hemorrhage and hypoxia. We should also auscultate the breath sounds, because breath sounds may be diminished or absent in the affected lung. Lastly, we must note chest expansion and position of the trachea, because chest expansion may be unequal until the lung that's affected re-expands, and the trachea may be deviated from the affected side.
As nurses, there are a number of different things we can do to help manage chest tubes. The first one is to make sure that the drainage bag is secured to a non-movable part of the patient's bed. This ensures that the device won't accidentally be tipped over. We also need to make sure that when we're securing the device to the non-movable part of the patient's bed, that it's below the patient's chest. This lets us use gravity to drain the pleural space. We also need to monitor the site at which the chest tube was inserted. We need to monitor for any signs and symptoms of infection. If an infection were to be present, we want to make sure we can catch it early and treat it appropriately. We also may need to make sure that the site itself is covered with an airtight occlusive dressing. This is to make sure that no further air is entering the pleural space, so that airtight dressing just helps and keeps it nice and secure. We want to make sure that in the water seal chamber we see titling, like with expiration and inhalation. If we didn't see titling, it could lead us to believe that the chest tube may be obstructed, or that the lung has re-expanded and the chest tube's no longer needed and could be discontinued. We want to make sure that we see continuous gentle bubbling in the suction control chamber. And we also, we can see occasional bubbling in the water seal chamber, and in somebody with a pneumothorax, that would be an expected finding, as bubbling in the water seal chamber indicates some type of air leak. The last thing we want to do is, in the situation that the chest tube would become dislodged from the patient, we immediately want to cover the site with a sterile gauze and tape it on 3 sides. We don't want to tape it on 4 sides, as this would occlude the dressing and could potentially lead to a tension pneumothorax. So priority in that situation would be to cover it, but only tape it on 3 sides.
So this right here just illustrates the various chambers that you have within the chest tube system. So this first chamber here is going to be for drainage. So this tube right here is coming from the patient, and the drainage is just going to drip down into the bottom of that tube. And then the air is going to continue into this next chamber, which is going to be the water seal chamber. And as she mentioned earlier, you want to see tidling in this chamber. So with inspiration and expiration, you're going to see that tidling, and then you may see occasional bubbling, but you don't want to see continuous bubbling because that is going to be indicative of a leak. So then the air bubbles that are coming out of that pneumothorax will come into there, and then this next tube leads to your suction container. So your patient can either be connected to suction or they can be connected to water seal. If they are connected to suction, you should see continuous bubbling in this chamber. If not, then you won't see anything going on in this suction chamber. And then that's just going to go to this next tube that's actually connected to the suction. And then those are the three chambers of the chest tube. Okay, so this picture right here is just, it kind of has to do with the placement of the chest tube. So this is going to be mid-axillary between the 5th and 6th intercostal space. And it's just going to be secured there with sutures. And then this is kind of what that illustration on the last slide was talking about. This is called an atrium. There are various different manufacturers who make these, but this one in particular has the water seal chamber down there. And this right here can be adjusted according to what type of suction or how many millimeters mercury of suction that is ordered. So you can just turn this little knob and change that. And then the drainage is going to come into here. So your drainage is going to fill up this, and then when it gets to the top, it'll spill into the next chamber. So you'll just measure according to however far that how far the drainage has come up. And that's those. And then these are the references that we used for the various journal articles that we have.
Nurses encounter over 20,000 cases of pneumothoraces in the United States each year. So it's important for us to continually reassess evidence-based practice and incorporate it into our patient care. Thank you for watching.